So today I'll be giving you an update on where we are with implementing BeginNGS. So I get the privilege of representing my colleagues at Rady Children's and our consortium members. So I'd like to just acknowledge and thank the contributions of individuals at these organizations for getting BeginNGS to where it is today. So what is BeginNGS? This is really kind of a vision statement that we have that we use to prioritize our research initiatives and implementation plans really aimed at catalyzing widespread adoption. So BeginNGS is an adaptive precision medicine delivery platform. So I want to emphasize it's not just a sequencing test. It's intended to be scalable. It relies on a fair amount of automation that will be aimed at minimizing the number of cases that require expert review. It's also a guidance system to help parents and physicians that do screen positive for what follow-up care is necessary. So the intention is in time BeginNGS will expand to provide screening across the lifespan of an individual. So the idea is that we can go back and reanalyze these individuals' genomes based off of their age and what they're interested in finding out at later times. So why are we doing this? It's probably pretty evident to most of you all in the crowd, but here's some actual evidence to help support this. So we analyzed a cohort of infant mortality from San Diego using our BeginNGS test to identify individuals that had potentially preventable diseases. So I've highlighted here, coincidentally, the exact same disorder that David went into yesterday. And so this is a thiamine transporter deficiency. And if you were a physician that didn't know David, what you could do is go to our GTRX web-based resource for physicians to identify treatment options and confirmatory test options to find out that this is a treatable condition with vitamin supplementation. And so you can imagine a scenario where we identify these patients before they become symptomatic, and this individual and this family would have had potentially a very different outcome. So our current focus, we have completed phase 1 and are just wrapping up phase 2 at this stage. So phase 1 was really a retrospective analysis and was published last year. And now we're completing our phase 2, which is another retrospective analysis on a much larger cohort with additional variants and additional disorders that we're evaluating. It also has now a kind of pilot scale prospective study where we are enrolling 85 patients that come from our Rady NICU, but they're patients that the clinical team has categorized as unlikely of having an underlying genetic etiology for their presentation. So things like isolated prematurity, hyperbilirubinemia, those type of presentations. And so these, while we've primarily been focused within the Rady ecosystem, we're now ready to pivot and really focus on scale since we've worked so hard at this point to optimize our test. So the next phase is going to expand beyond Rady to include other healthcare systems, both in San Diego as well as additional states, and with the end goal of getting to the point of being able to analyze 100,000 to 1 million babies a year. All right, so just a kind of dashboard view of where we are with our prospective study. Again, we have a consortium of 23 partners. We're assessing roughly over 400 conditions at this point, and we have 7 working groups. And so our working groups are really focused on things like assessing our gene and condition list, as well as our technology, data management, data science to help us with scalability and things. And then another working group, for example, around clinical implementation that focuses on developing a clinically valid test and what type of return of results we are. So it's a very cross-functional, interdisciplinary team that's tackling some of these big challenges that we've all highlighted today. To date, we have, this is now out of date as of this morning, 74 newborns enrolled in our prospective study, a consent rate of roughly 46%. And just highlighting the diversity of San Diego County, of our enrollees, 74% self-report as being of a different race or ethnicity other than white or non-Hispanic. And this largely is exactly in line with the birth demographics for San Diego County. We've had 63 complete tests returned and resulted to patients. We have a 3% positivity rate, and these have been analytically confirmed and are true positives. And we really emphasize speed, and so all of our turnaround times are less than 14 days. All right, I'm gonna pivot to our retrospective analysis, where we are really focused on assessing the performance of this test. And so for this sensitivity assessment, we use our Rady diagnostic whole genome sequencing cohort. So one of the things that we've all talked about is concerns about performance across different ancestries, and so that's something that we were really trying to test and assess with this version of our analysis. And so what's plotted here is just a genome-derived ancestry from our diagnostic whole genome sequencing cohort, demonstrating that we capture a wide range of diversities in our cohort. So in terms of what our BeginNGS test is really utilizing in terms of automation, this is very similar to what other groups are doing and have described to date, but it's essentially a set of variants that we're using to, as well as kind of novel loss of function and ClinVar and copy number variants. So it's ClinVar, likely pathogenic and pathogenic, as well as novel loss of function and copy number variants that lead to monogenic disorders. Also trying to incorporate some additional evidence from the literature using Genomenon and an AI prioritization and decision support tool that we're analyzing and assessing with our partners at Fabric. So at this point, we have really high sensitivity. When utilizing all of these different resources, we're able to recall over 88% of our findings from our diagnostic lab. Okay, so I want to spend a minute here to explain what I'm about to present. So a lot of, as we start to scale up and launch these large prospective studies that are likely to yield critical insights in terms of clinical utility and healthcare utilization, in the meantime, over the coming years, we can use our retrospective study to start to assess some of these metrics with a counterfactual analysis. And so what that means is getting really deep in the charts for these patients that have consented for additional data use and research use to try to say, in this scenario where they had diagnostic genome sequencing well after they became symptomatic or right after they became symptomatic, what would have been the outcome from both a clinical utility as well as an healthcare economics perspective if they had been diagnosed at day of life 10 or screened positive at day of life 10 before being symptomatic. And so what that involves is a really deep chart review by our medical team to try to quantify the healthcare utilization and different tests, et cetera, that these patients received at the time versus what could have been avoided if they had been screened prior to that. So there's a lot of details up there. I don't intend for you to really take that all in, but the idea is it's not just medical usage, but it's also things like psychosocial estimates that, for example, a lot of these babies we found in the chart, based off their review, were actually having child protective services involved because they were failing to thrive. So it's things like that that we're trying to measure instead of just the tests and care support that these infants required. So the next step after this is that they'll go to a wider physician panel to confirm and come to a consensus on what could have been avoided, and then go to our healthcare economic friends to talk about to estimate the cost efficacy of what the outcome could have been with the screening test and set. So this is all methods that we developed for our diagnostic whole genome sequencing and utilized from our project Baby Bear that really demonstrated the clinical utility of rapid diagnostic sequencing, and so that's a similar approach that we're using with this. So in summary, we're really implementation focused. Scaling is really our next critical step, where our prospective studies demonstrates high enrollment and a diverse participation and fast turnaround times. Our retrospective study really identified really clarified the evidence around unmet need, high sensitivity and specificity, which I didn't get a chance to talk about for scalable automation. Clinical utility assessment is underway, and we really hope that, similar to rapid diagnostic whole genome sequencing, that this whole effort by this collaborative group will demonstrate and catalyze widespread adoption.